All right, let's talk about leukemias. We're going to do a basic intro plus signs and symptoms, then take a look at the leukemia family tree, how to distinguish between the four major types of leukemia, and then we're going to dive into each one of them. And finally, we will look at hairy cell leukemias. So again, leukemias are cells in the blood and the bone marrow. Typically, they are of lymphoid origin, where B is greater than T, but they can also be of myeloid origin. So a couple signs and symptoms of leukemia, like all cancers, cachexia, weight loss is a symptom due to TNF alpha production, which causes catabolism of fat and muscle cells. Swollen lymph nodes, these should be painless. Again, you might see this in lymphoma. That would make a little bit more sense. Typically, this will be indicative of the fact that a leukemia has infiltrated a lymph node. And most of the symptoms, though, are due to inappropriate hematopoiesis. So if your bone marrows are not producing the red blood cells, the platelets, the leukocytes that you need, your liver and your spleen and your skin will take over. This will cause hepatosplenomegaly, but it will also cause what's sort of blueberry-looking skin. And these are all extramedullary hematopoiesis, other organs trying to take over the job of hematopoiesis from your bone marrow. No red blood cells will cause fatigue and weakness. So much cell proliferation will also be associated with a lot of cell death. This causes a lot of cell turnover, which is associated with bone pain. And similarly, if we have a lot of cell turnover in the bone, there's a lot of calcium, a lot of hydroxyapatite, and then that is going to be spilled into the plasma, which might cause hypercalcemia. If I don't have appropriate hematopoiesis, I don't have neutrophils, and this might lead to infections. And lastly, without the thrombocytes, I might develop nosebleeds, easy bruising, bleeding, and perhaps a petechia. Remember that platelets are associated with more superficial bleeding as opposed to deeper joint bleeding being associated with coagulation cascade. And so let's take a look at these five major types. So again, this is all in the bone marrow, and it's either going to be blasts if it's acute, or if it is chronic, it'll be of the mature form. So when you're looking at any of these names, the first letter is whether it's acute or chronic. So I'm looking at acute, chronic, acute, chronic. Acute means immature, chronic means mature. And then the second letter, L for lymphoid or M for myeloid, lymphoid and myeloid. So these would be ALL would be an immature lymphocyte, so B or T cell that's immature. On the other end of the spectrum, CML would be chronic, meaning a mature, differentiated cell, not a blast, and M being of the myeloid origin. So this could be an eosinophil, basophil, or neutrophil, probably a neutrophil because that's the most common one. So I like looking at it in this simple spectrum. You can think of the M's as being associated with medial. These are in the middle. And then other than that, it's just alphabetical. So A would be on the left end of the spectrum and C would be on the right end of the spectrum. And you can kind of ignore that. So again, M is going to be in the middle, and these are associated with middle ages. And then alphabetical A is associated with kids. Again, this is the young, and this is the old. And then the C is going to be associated with the elderly. That's actually really helpful. Like, if you don't know anything else, that can be very informative when you're trying to decide what the answer is in a vignette. And we've already talked about the etymology, right? The ALL, A, acute, immature, L, lymphoblastic. This is an immature lymphocyte. Immature myeloid, mature lymphocyte. For the histology, A for hour rod, so think A for hour. And similarly, you can think of M for myeloperoxidase. What's the link between these two? Well, an hour rod is simply just a precipitation of insoluble myeloperoxidase enzymes. We have a smudge cell for the CLL. And then for the stains, the proteins that we see, TDT, terminal deoxytransferase, is going to be helping promote genetic diversity for B cells and T cells. And if it is a B cell, remember the the lymphocytes could also be a T origin, CD10 is going to be present. Translocations 1221 is going to be the good prognosis for minors. 922 is the Philadelphia chromosome. This is going to be associated with a worse prognosis for older individuals with ALL. 1517 is sometimes present only if it's APML, also known as APL, acute promyelocytic leukemia. And 922 is going to be the main instance where we see the Philadelphia chromosome on CML. We also have hairy cell, which is going to be mature B cell, hair-like histology, and then a trap stain. So quick note for any sort of lymphocytic markers. So anytime we're dealing with a lymphocyte, the smaller numbers, 1 through 8, are T cell, and the larger numbers, 10 through 23, are going to be B cell associated. But on top of that, notice that here we're in the blast region, anything to the left of this. And for the blast, I have TDT and TDT, and again, that's because TDT randomly adds nucleotides to promote more diversity for antibodies and T cell receptors, so via recombination. And then the CD10 is a marker specifically for immature B cells. So that can tell us if it's lymphocytic versus myeloid, and then if it's a mature lymphocyte versus an immature lymphocyte, and then specifically if it's an immature B lymphocyte versus an immature T lymphocyte. All right, let's start with ALL. So ALL is the first in our spectrum. We can think of it as alphabetical. This has to deal with kids. Now, this is an average. Can an adult get ALL? Yes, but more often than not, this will be a kid, and it's just rare. The other leukemias typically do not affect kids. So if it's a kid, it's pretty safe to say it's a Hodgkin's lymphoma or an ALL, acute lymphoblastic leukemia. So as we said, immature lymphocytes. This is the most common cancer. We talked about this in the first section, epidemiology. So not just the most common leukemia, the most common cancer for kids. It is TDT positive to promote recombination and diversity, and CD10 if it's a B cell. 1221, again, think of this as a mirror, right? 12, the mirror would be 21, right? You think of like RS in organic chemistry. That is a mirror, and it is for minors because ALL is for minors, and it's also a minor prognosis. On the other hand, 922 is for is the Philadelphia chromosome. This would be adults with ALL, which is less common, and it would be a worse prognosis. Usually it's B cells. If it is a T cell, it'll be a large mediastinal mass. Well, how do we remember that? Remember the thymus is in the mediastinum. So if I have a T cell leukemia, it would make sense that my thymus is going to be quite enlarged, and so I'm going to have an engorged mediastinum. Sanctuary sites, so where chemotherapy might not infiltrate, might be less effective, or metastasis might occur, is in the testes for boys. And so then when this is followed up by radiation, this might lead to infertility, also in the brain and the central nervous system. AML, again, the M's are for middle-aged, and so this might be like 50 or 60 on average. And again, that is an average. You can have any different age, so just keep that in mind. Immature myeloid, we get that from the name. Myeloperoxidase, remember that to generate bleach, HOCl radical from hydrogen peroxide, we use MPO, myeloperoxidase. This is in neutrophils. This is something we talk about in immunology, so it should make sense that this shows up here. And I think of this M as standing for myeloperoxidase, and this M as standing for hour rods. What's an hour rod? It's just a bunch of MPOs that are precipitated together. This is very high yield to be able to recognize this on a histological slide. If the hour rods somehow get into contact with the rest of the plasma, this can lead to disseminated intravascular coagulation, DIC, where we might have lots of coagulation in one region, which uses up all of our clotting factors, and so we have no clotting in the next region. 1517 is a translocation that sometimes occurs, probably a minority of the time, but sometimes you'll see it. And specifically, it's an all-trans-retinoic acid receptor that is defective. This is called acute promyelocytic. So sometimes APL, sometimes APML. And well, it's the all-trans-retinoic acid receptor that's defective. So this particular cancer might respond to all-trans-retinoic acid, which binds to this upregulated receptor. This is really just vitamin A. Note that this does not kill the APML or APL. It merely causes them to differentiate, right? Acute is blast, their immature. M is myeloid. So this causes them to mature to differentiated neutrophils, which can somewhat attenuate the cancer presentation. AML might be caused by other types of cancers. So myelodysplastic disorders, where we have excessive proliferation of myeloid cells in the bone marrow, often it's as a result of chemotherapy and radiation. So I've bolded this because this is really important. This can cause the myeloplastic disorder, which then might cause AML to develop. CML is chronic myeloid leukemia. This can technically progress to AML. So we'll see this in a hot second right here. So CML, Remember that this is technically a myeloproliferative disorder, not to be confused with a myelodysplastic disorder, which is caused by radiation or previous chemotherapy. Again, M for middle age. So this is middle-aged individuals, 50s, 60s on average. And it is mature myeloid, as we get from the name. And myeloid is, again, eosinophils, basophils, and neutrophils, mostly neutrophils. 922, Philadelphia chromosome, count them out. That's 22 letters and is associated with the 22 over here. That's how I remember it. BCR ABL. So BCR is just a gene that's upregulated in leukocytes. ABL is a receptor tyrosine kinase that is pro-mitosis, pro-division. And this is why we might have this become cancerous. Imatinib, which is a really great drug that came out in the early 2000s called Gleevec. It's a really effective chemotherapy drug. I think the mortality rate, like a 5-year survival, was 22%. Before 2004 or something, before Gleevec, and then after it was like 90+% survival. And it's just a pill. I mean, this is an amazing drug. Note, as we just saw on the last slide, that CML can progress to AML. Now, how do we differentiate this? So this would be AML. So maybe we have 1,000 cells here. Let's pretend that there's 1,000. We count them all up, there's 1,000. Now, these neutrophils that I'm looking at here, and again, we can see this characteristic nucleus for these neutrophils. Maybe I count these and I see that there's 100. So that means 10% of my cell might be, the myeloid origin or blast or something. But as the disease progresses, we might have something that's called a blast crisis, where now the bone marrow has more than 20% cells that are blast. And notice here we can see that there's certainly a lot more. So maybe it's still 1,000 cells total, but now I count them up, maybe now there's 300. So now this is 30%. It's an arbitrary cutoff, but if we're over 20% of cells in the blood smear are blast, we now call that AML rather than CML. CLL is the eldest. Remember our spectrum, we had ALL, then we had the M's for medial, and then we have CLL as for the elderly people. So these are on average old. They could be younger, but they're probably going to be old. Mature lymphocytes from the name, smudge cells is the histology we look at, and it progresses really slowly. So this, in combination with the fact that it's elderly individuals, means that, if you've got someone in their 80s who has a cancer that takes 10 years to develop, you might not go for really aggressive chemotherapy. So we're going to give them a very mild treatment. If anything, sometimes we don't treat them at all. Sometimes a Richter transformation occurs, which is where the CLL will sort of morph into an aggressive, diffuse large B-cell lymphoma. Lastly, hairy cell leukemia. So hairy cell is going to be in adult males. I think of adult males as hairy, having hairy legs. They're going to be mature B cells. And the histology, filamentous hair-like projections. We can kind of see this here. We can see these sticking out a little bit. A dry tap, just like we saw in myelofibrosis, the chronic myeloproliferative disorder. So if I don't have hematopoiesis going on in my bone marrow, I'm going to find other places to do it. We're going to look at the spleen. We're going to look at the liver. So hepatosplenomegaly is going to be common. And maybe the blueberry skin is our skin is now trying to produce white blood cells and red blood cells. So extramedullary hematopoiesis. And then pancytopenia, because even though we have extramedullary hematopoiesis, it doesn't work nearly as effective as the bone marrow. So I'm going to have a deficiency in red blood cells. I'm going to have a deficiency in platelets. I'm going to have a deficiency in white blood cells. And you can then imagine that that's going to cause things like fatigue and chronic infections and easy bruising, things like that. TRAP, tartrate-resistant acid phosphatase, is a common stain, is a commonly upregulated protein that we see in these particular cells. And hairy leukemias are associated with the BRAF mutation.